Who is presenting?
Sir, myself is presenting, sir. Nutrition in ICU. Uh, Today is my topic is about nutrition in ICU, sir. Introduction. Nutrition therapy is a cornerstone of intensive care and integration of management of all patients. Malnutrition is common in ICU patients in 38 to 78% of patients and can worsen rapidly due to stress response, hypermetabolism, catabolic state of critical illness. Early recognition and active nutritional support optimizes the immune function, wound healing, organ maintenance, recovery, while reducing the complications and mortality. Critical triggers complex systemic stress response involving neuroendocrine and inflammatory pathways. There are three phases. The first phase is M phase. It lasts for first 24 to 48 hours. It has relative hypometabolism, preserved endogenous glucose production, high stress hormone release, cortisol, adrenaline, ACTH, and cytocholamines, interleukin 6, and tumor necrosis factor alpha. The second phase is flow or hypercatabolic phase. It lasts for 3 to 7 days. In this phase, we have accelerated muscle breakdown, increased energy and protein requirement, insulin resistance, enhanced glucose and lipid metabolism. Recovery and anabolic phase. This is after 7 days. It's a gradual rebuilding and tissue repair phase, requiring high protein and nutritional intake. What are the consequences of malnutrition in ICU? Muscle wasting, respiratory muscle weakness, impaired immunity, increased infection, sepsis risk, delayed wound healing, pressure sores, prolonged ventilation, mechanical ventilation, increased length of stay, higher risk of mortality. So how we assess this one? There are nutritional assessment and risk stratification. All patients in ICU should be assessed for this nutritional assessment by history or clinical examination, by recent weight change, BMI less than 18.5 to 20, prolonged reduced intake, underlying comorbidities, and nutritional scoring systems such as Nutric score, NRS 2002, subjective goal assessment, laboratory markers such as albumin and hello. Hello, sir.
Yeah, please proceed.
Yeah.
Okay, sir. Nutric score, NRS 2002, subjective global assessment. Laboratory markers such as albumin and prealbumin, it correlates poorly with nutrition due to acute phase, but can be followed for trends. Anthropometry used for serial assessment, limited by fluid strips in ICU. Indirect calorimetry, it's a gold standard for measuring energy expenditure where available. Otherwise, pre-acute equations, example, Harris-Bendris method, or 25 to 30 kilograms per calorie per kg per day are used. Functional methods such as grip strength, physical activity levels can also be assessed. What are the nutritional requirements in the patients in ICU? Energy. Initially, in 3 to 7 days, 20 to 25 kilocalories per kg per day is needed. Avoid early overfeeding. Increases 25 to 30 kilocalorie per kg per day. Thereafter, based on phase, comorbidities, measured expenditure when available. Use ideal body weight or adjust body weight. Normally use ideal body weight. For obese patient, we can use adjust body weight. Protein, critically in ill patients, we need 1.2 to 1.5 gram per kg per day, up to 2 to 2.5 gram per kg per day during recovery phase or in burns and polytrauma patients. In renal failure, with no dialysis, we require low protein target of 0.8 to 1 gram per kg per day. If the patient is on dialysis or CRRT, high protein may be required. Fat and carbohydrates balance is required. Each should be contribute to overall calorie needs. Avoid excessive carbohydrates to reduce hyperglycemia and lipogenesis. Fats requirement is 0.8 to 1.5 gram per kg per day. It is approximately about 30 to 40% of total intake. Micronutrients requirement for selenium, zinc, copper, thiamine, and other vitamins are often higher due to increased losses and consumption by metabolically active tissues. Thiamine and vitamin D deficiencies must especially be considered in prolonged ICU stay patients. Modalities of nutrition support. The first preferred one is in oral diet. It is a preferred route if the patient can eat safely and meets at least 75% of oral needs, and oral supplements can be considered if inadequate. Assess for risk of aspiration, mental status, and swallowing functions. The second one is enteral nutrition. The enteral nutrition is a standard care in most of the ICU patients who cannot maintain an adequate intake orally. The timing, it should be initiated within 24 to 48 hours if hemodynamically stability is present. BP is more than MAP is more than 60 millimeter per mercury, and low vasopressor doses. Methods, we can use the nasogastrics or nasojejunal or orogastric tubes. For long term or high aspiration risk, post pyloric feeding is preferred. Advancement, start with mild feeds 22 kilocalorie per hour or low volume feeds, gradually increases as tolerated over 2 to 3 days. Formula feeds, standard high protein, fiber enriched or disease specific, such as renal, hepatic, and immunonutrition formulas as appropriate. Complication, aspiration pneumonia, diarrhea, high gastric residual volumes, constipation. For this, we have to regularly monitor regular abdomen examinations, GRV checks, stool charts, test imaging if necessary. Para-enteral nutrition indication for non-functioning or inaccessible GI tract, failed or contraindicated enteral feeding, persistent feeding intolerance, or when enteral nutrition cannot meet more than 60% of daily needs by day 7. Most commonly, we use two types of parenteral nutrition is available: central and peripheral parenteral nutrition. In most ICU, the peripheral parenteral nutrition is used, and formulations, it has amino acids, dextrose, lipid emulsions, electrolytes, vitamins, and trace elements. Risk, for the patients on parenteral nutrition, the risks are catheter infection, hyperglycemia, hepatic dysfunction, electrolyte disturbances, and refeeding syndrome. Initiation, typically it after 3 to 7 days if enteral nutrition is not possible. Avoid early full calorie parenteral nutrition. For the patient who is on nutritional therapy, daily we have to monitor fluid balance, electrolytes such as sodium, potassium, calcium, magnesium, phosphate, glucose, urea, creatinine, liver enzymes, and weight, preferably dry or corrected. And signs of overhydration or depletion should be monitored. Gastrointestinal, abdomen distension, bowel sounds, stool frequency, and consistency should be measured. Feeding intolerance, vomiting, diarrhea, and aspiration risk. Metabolic symptoms such as hyperglycemia, hypoglycemia, refeeding syndrome. First week of therapy, look for hypophosphatemia, hypokalemia, hypomagnesemia, hypertriglyceridemia with lipid administration. Infection and sepsis, catheter side systemic markers such as especially in patients with parenteral nutrition. Complications for nutrition support. Aspiration pneumonia. For preventing this aspiration pneumonia, always keep the patient in head and dilution more than 30 degree. Use prokinetics agents. Post pyloric feeding in high risk patient. For diarrhea and constipation, modify the formula. Use fiber. Consider anti-motility drugs in diarrhea and laxatives in constipation. Refeeding syndrome. Monitor closely the patient during the first week. Replaces the potassium, magnesium, phosphate, thiamine aggressively as indicated. Metabolic condition of hyperglycemia should be managed with insulin protocols, overfeeding, and hepatic dysfunction. Mechanical tube dispersion, blockage, and displacement. In special populations, in obesity, use adjust body weight, target hypocaloric, high protein diets, especially avoid overfeeding as it increases infection, hyperglycemia, and respiratory overload. In burns, trauma, and sepsis patient, the patient may have need patient will be hyper metabolic and they have high protein demands. The energy up to 30 to 35 kilocalorie per kg per day is needed, and protein as high as 2.5 grams per kg for severe burns is required. In renal and hepatic dysfunction, adjust the fluid, protein, and electrolyte administration. In dialysis patient and non-dialysis patient, the protein adjustment should be needed. In refeeding syndrome, it has a greater risk for malnourished, chronically ill, started on feeds. Monitor closely for electrolytes, volume overload, and supplement the diamond. In the refeeding syndrome, especially after starting feeding, start slow, advanced feeds over 4 to 7 days. As per the ESPN guidelines, start enteral nutrition within 48 hours if feasible. Assess all ICU patients for malnutrition. Avoid early full energy feeds. Use parenteral nutrition if enteral nutrition is not possible or fails to provide 60% by day 7. Monitor for refeeding syndrome. Target protein is about 1.3 per kg per day is used. That's all, sir.
So the nutrition is a big topic, and as you have to really get the answer within the given time. Because you have made a good presentation of all the points, I'll just share my screen to show you how you can make it some more